tell you, it was a younger patient. And she came in with her mother, and she just was not making eye contact. And it was very hard to evaluate the patient. And I had gotten an email from the team asking if it was okay to do this injection for the patient. So they sent me an email asking if it's okay to treat somebody under the age of 18, because I don't traditionally do it. And we got parental consent. She came with her mother, and I felt so bad for her because she had tried everything, TMS and therapy, medications, ketamine. She'd gone through the gambit of everything. And so to my mind, I felt like she met the criteria and would be a good candidate for the SGB, or the stellate ganglion block, also known as a God shot, by the way, on Reddit, which I just recently learned about.
A God shot.
God shot.
Okay.
It's a pretty cool nickname.
Yeah, I think so too.
So I didn't want to exclude her from the therapy because she just, been through a lot. And when I saw her, she wasn't making eye contact. She actually had headphones on, big headphones like the ones I got on right now. And, I talked to her mom. I kind of gave her the lowdown on what the injection is, what to expect, and all that. Took the patient in the room with her mom into the operating room because she had so much anxiety. Right. Gave her medication. She went to sleep, did the injection. I didn't see her after that for quite some time. 6 months later, I come walking in the preoperative area, ready to take a patient back for a stellate ganglion injection. And, I kind of do a double take. I go back, and I see there's a woman sitting next to the bed, and it was that woman's mom. And I looked at the girl, and she had her headphones off, and she was smiling, and she was making eye contact. And I looked at the mom and said, "Is this the same girl, or does she have a sister or something?" And she goes, "No, this is her now. Like, look at how much her life has changed from where she was at to where she's at now." And at that moment, I realized, I was like, this thing works.
Yeah.
And it was from that point on where I started telling my friends about it, that, if you've got mental health issues, first and foremost, see somebody. Second of all, understand that there's different tools that we can use nowadays that are safe and effective. And so, just an anecdotal story there, but I've seen people from all walks of life, all professions. I've seen famous businessmen to famous tattoo artists to you name it, people traveling from San Francisco, from Houston, from the Midwest. And it's interesting to see all these people from different walks of life suffering from the same thing. And so far, I think about an 82% success rate.
82%. All right, everybody. Welcome back to the No Supervision podcast. We got a treat for you today. Mostly what we talk about on the show is, talk therapy. We also, at some point, I'll talk more about medications. But now we got somebody that can offer mental health treatment that is not just medications and not just talk therapy. I'm happy to have you here. Thank you for coming.
Thank you for having me. It's super exciting.
All right. So to start the show, I always let people take a few minutes or a few seconds, however long you want, to introduce yourself, tell them your name, what you do, and how you got to where you are in life right now with your practice.
Awesome. So my name is Armen Haroutunian. I am a anesthesiologist, and I'm double board certified in pain medicine as well. Interventional pain management, that is. I was born in Spain and Madrid, and I was pretty young when I moved out to California and sort of grew up in this state, grew up in LA for the most part, went to La Cuneta High School, then went to UCLA for undergrad, and then went to medical school and lived in Chicago for a little bit, in New York, and finally came back to California, where I got my second degree in interventional pain medicine at UCLA. So now I'm back here, and love to be back.
You speak 3 languages. Is that correct?
I do, yes.
That is how I looked at your website and I saw that you spoke 3 languages.
Yes, sir.
I've been trying to learn Spanish for 15 years. I can't.
It can't be too hard. I mean, Southern California is definitely the place where you want to know how to speak Spanish.
Agreed.
I think my second language to pick up is probably going to be Korean.
Korean?
Yeah.
Wow.
Yeah.
So what do you speak? You speak English, Spanish, what else?
I speak English, Spanish, Armenian, and that's about it for now.
Okay, and then Korean. Maybe.
Yeah.
Okay.
Yeah.
Awesome.
Yeah.
Okay. Yeah. I'm very, very jealous. Okay. All right, so we kind of got a glimpse into your career path. The question
Yes.
is, what inspired you to go into pain management? Is that how you would characterize anesthesiology and pain management? What
Correct.
inspired you to go into that?
Yeah, so it sort of, I don't want to say it fell into my lap, but things, the stars kind of aligned in the sense that I initially wanted to go into vascular surgery. And so that was kind of my passion at the point. But it just so happened that I also applied to anesthesiology, and a great opportunity for me opened up in Chicago. And so I took that opportunity, and my passion for it really stemmed from my interest in physiology, my interest in how the body works, most notably all the organ systems, the heart, the brain, the lungs, the kidneys, they all kind of come together when you do anesthesiology.
Mm-hmm.
And also intervention. So I wanted to do stuff with my hands. I really like the surgical component. So in my view, it was kind of the best of both worlds, where I got to experience a surgical component and also provide care and kind of be, as they call, like the gatekeeper to surgery or whatnot.
Okay.
Yeah.
This is actually around the time that I think is important for my next question, which involves ketamine. Okay.
Definitely.
I mentioned at the top of the show, medications, talk therapy. This is something that is, traditionally speaking, what psychiatrists are most aligned with. I'd say the past 5 years or so, ketamine hasn't been around a long time, but I feel like it's now much more accepted now than it was 10 years ago or even 15 years ago. Can you talk to us about how you use ketamine in your practice, what it does, how you use it, what's its effectiveness?
Yeah, certainly. I think it's a very interesting drug.
Yeah.
Okay. And some of us have heard about it through the medical field. Others have heard about it as a street drug. Ketamine's been around since the 60s. Since the Vietnam War, we used it during the war for combat veterans. They would sustain blast injuries, lower extremity injuries, or whatnot. You want to kind of pull them off the field and administer the medication. So you give them some pain relief and some anesthesia at the same time. So classically, notably known as an anesthetic and a dissociative anesthetic, meaning it kind of dissociates you from the state of your physiological being. So you kind of view yourself as a third party. So it's known as an anesthetic, been around since the 60s, but it's made tremendous waves. We've used it in anesthesiology. I continue to use it nowadays, but I would say probably within the last 10 years, it's gained a lot of traction in psychotherapy and psychiatry. We noticed that some of these combat veterans that we were treating for pain were having these secondary gain effects of reduced anxiety, reduced depression, less risk of overall suicidality and self-harm. And so I think that's where the awareness came in. And up until 2020 is where we started really putting out big studies. And I think recently, as of this year, the Clinical Psychology magazine put out a pretty large randomized controlled trial of about 400 patients where they administered ketamine, and they noted a 70 or 75% reduction in anxiety,
Wow,
and depression and self-harm. So I think all these things have kind of lined up, and it's definitely become a drug of choice for treatment-resistant depression and PTSD, which I'm sure we'll talk more about. But it's got a great safety profile. It's cheap to make and widely available. But with everything comes its cons, right?
right.
So some of the cons, if it is cheap to make and widely available, it ends up being a street drug and illicitly abused. And I think that's where it kind of has this negative connotation nowadays, where you hear ketamine, you're like, oh, I don't want anything to do with that. But on the flip side, if it's done in a safe environment, has tremendous properties, which I'll delve into for sure.
Yeah. So wait. So it was initially used for anesthesia,
Correct.
and people discovered that it was beneficial for anxiety, depression, PTSD.
Exactly.
Yeah.
And we still use it for anesthesia. I mean, I will, sometimes patients are better suited for ketamine as opposed to something like propofol if we're trying to put a patient to sleep. If they got like a large airway, if they're more, prone to obstruction, meaning they've got a thicker neck and you don't want them to obstruct and stop breathing, ketamine's a great option because it keeps them spontaneously breathing, thereby mitigating that risk of them stopping breathing and obstructing the airway. So in those circumstances, we like to use ketamine, and we'll still use it in the operating room. We'll give some doses here and there to reduce postoperative pain helps us reduce how much opioids we use in the operating room because it's got that beneficial property of pain control through this partial mu receptor agonism, which is how opioids work. But its main mechanism of action is not that. It's actually NMDA receptor antagonism. That's its main mechanism of action. And by antagonizing that NMDA receptor in our body, it creates all these beneficial secondary effects like reduction in anxiety, depression, PTSD, and pain. More specifically, NMDA has a whole cascade of effects, and that cascade of effects translates to reduced levels of certain enzymes in our mind and body called epinephrine and norepinephrine.
Mm-hmm.
These are some of our fight or flight response hormones that are usually completely out of alignment in cases of chronic pain and PTSD and anxiety. And so when those levels get regulated, that's when we see improvements in these different kinds of mental health conditions. That's how ketamine really works, is it reduces those levels of norepinephrine and epinephrine, which are flight or fight hormones.
Through the NMDA receptor.
Correct.
Okay.
NMDA receptor antagonism.
Now, can you go back just a few steps for the NMDA receptor?
Sure.
Okay, because we're learning about all this stuff pretty recently. You've mentioned that we were using it for anesthesia, and now we're using it for anxiety, depression. So many things in medicine. Viagra, for instance, we're using for medicinal purposes.
Right.
They find out other stuff about it. Okay, so what's the NMDA receptor? What does that do normally in the body or the brain?
So the NMDA receptor, it's got a prevalence of receptor neurons in the brain plays a role in the limbic cortex, which is like the hypothalamus. It is your amygdala, which is like a little almond-shaped mass in the brain. And this limbic cortex is usually responsible for emotional control, how labile somebody is, how moody somebody can get. And so a lot of these pain pathways, a lot of these anxiety, PTSD, depression pathways, they kind of coalesce in this limbic cortex, and they kind of like talk to one another. And what the NMDA receptor, when we block it, what it does is it reduces, again, those circulating levels of epinephrine and norepinephrine, which ultimately act upon that limbic cortex. So by reducing those levels, you have a less effect of the norepinephrine and epinephrine, the fight or flight hormones, on the limbic cortex, which is responsible for the emotional control and all that stuff. So it's almost like a mental reboot where we all of a sudden shut off those high levels of enzymes that are responsible for upregulating that limbic cortex.
Right. So what you're describing, I know. So I've mentioned the amygdala a few times on this show before. The amygdala has a lot to do with your emotions. The hypothalamus has a lot to do with the release of hormones, just chemicals. Epinephrine and norepinephrine is essentially just adrenaline. It's just adrenaline. Okay. So if you can imagine, if a lot of the things that ketamine is impacting on, it's going to impact on your emotions. It's going to impact on your fight or flight response. It's going to impact on norepinephrine and epinephrine, which is just adrenaline. You calm that down, you calm down. Is that a good summary?
That's a pretty good way to put it. I like that.
You calm that down, you calm that down, and you calm down. Okay.
Yeah.
Okay.
Calm your limbic.
Calm your limbic. Okay. Okay. So in terms of the public's perception of ketamine, you also mentioned this too, with it being used as street drug sometimes.
Yep.
It's still, I'm surprised that it would still be used as a street drug. There's so many other options out there, but it's still used sometimes recreationally by people.
Believe it or not, yeah. I guess kids nowadays, whatever you can stick in a microwave and turn into a powder, you can use it as a street drug. So I think that's where its kind of utility comes in. And like I said, it's a cheap drug, and it's got a safe profile, and I think that's what makes it so interesting and attainable for young adults. And I think the power of educating oneself online could be a double-edged sword, because a lot of our youth nowadays think they know it all, and they go online and they research it, and I read this and I read that. But at the same time, you got to know how to sift through that medical research. As medical professionals, we go through years of training of how to organize information, of being able to understand what is statistically significant, what is not statistically significant. And I think the layman is, without medical training, you may read something and think, oh, look at this. Even though something may be anecdotal, it doesn't necessarily translate to a clinical outcome. And so it's very dangerous reading what you read online. And I think, a lot of us youngsters have now kind of self-educated ourselves and think what we do is safe. But there's a right way to do something and definitely a wrong way to do something. But ketamine is definitely a street drug, and it's gaining much more traction, a lot more popularity. And the fact that it does have these kind of beneficial outcomes on anxiety in the mind and trauma, I think is making it that much more interesting for the young adults to try. But problem is, a lot of these medications are, you don't know what dose you're getting. You don't know what it's laced with. You could do a wrong dose of ketamine and definitely get into big trouble because it's got a lot of secondary effects like hypertension or increasing your blood pressure.
Yeah. What are the risks of ketamine treatment?
So some of the basic ones would be, dramatic increase in your blood pressure, which if it's uncontrolled can lead to heart attack and stroke, can increase your heart rate dramatically, which can give you symptoms of palpitations and throw you into things like SVT or supraventricular tachycardia. It can cause you double vision, anxiety. It can worsen cases of underlying schizophrenia if you don't know you have underlying schizophrenia. So these are things that, if not given by a medical professional, you can really, really run into some trouble.
Yeah. So what you just mentioned, because I'm thinking of also what I mentioned earlier with us discovering all these new positives of medications. We also use them, can discover new recreational uses. I remember cocaine used to be you guys still use cocaine for anesthetic, right?
Yeah.
Now it's a party drug.
Now it's a party drug. I know. You
very expensive party drug.
You can go daytime with hanging out with your ear, nose, and throat surgeon. He's using cocaine as a topical anesthetic, and you can go nighttime and see cocaine used by non-ENTs or maybe even sometimes ENTs.
Yeah,
So
yeah.
You never know how these drugs end up working out, and you're right. From every positive, there's a negative, but I think educating oneself about what some of the harmful outcomes could really deter a lot of people. So yeah.
I want to make sure before I move on to something else, is there anything else about ketamine that you want the people to know about it?
There's certain treatments that are recommended, certain protocols, for example, that are recommended. There's different ways ketamine is given. Ketamine could be administered orally, could be given in the muscle tissue, almost like a flu shot, for example, or it could be given through IV. So there's different formulators, different ways people administer ketamine. And for example, if you're given it orally, the oral availability or bioavailability is low. So you're not going to get that same efficacy or outcome as you would if you're going to get it intramuscular or intravenous. Now, intramuscular has also a good availability, but its mechanism of action and the way it's going to work is not going to be as quick or effective or easily titrated or dosed as an intravenous formula would be, right?
Right.
So there's different benefits to each modality of treatment. Some patients will get, for example, if we do a ketamine infusion, which I offer, if we do a ketamine infusion for somebody for chronic pain or anxiety or PTSD, those beneficial outcomes could persist for 3 months or 6 months or a year or indefinite. But typically we're happy if we see 3 to 6 months of
3 to
outcomes.
6 months.
Yeah.
That's amazing.
And each patient, it really is amazing. I mean, when you think about treatment resistant or treatment independent patients who don't respond to, biofeedback, which is, a modality that psychologists, psychiatrists employ, which is always kind of a first line treatment. Obviously you want to avoid the medication route if you can and trust your mental health professional in helping you through it. But sometimes we need assistance. And when those medications don't work, or, we start reaching levels of, okay, we've tried medications, we've tried transcranial magnetic stimulation. What could be the next step? Ketamine offers that route. So it's another tool in our toolbox that allows us to combat a problem, and a problem in some people that just don't respond to other modalities. So sometimes one infusion does it. In other occasions, we consider how they do and bring them back and reevaluate. It's where we usually like to work with mental health professionals and partner up with them because they kind of guide the treatment. We like to facilitate and administer the medication, but it's very individualized. Everyone's very different. So there's a dose that we start with. Sometimes 0.5 milligram per kilogram per hour is sometimes a dose we look at, and we gradually increase the medication as the patient tolerates it. And how do we know if someone's tolerating it? Verbal feedback. We look at their vitals. We look at their heart rate and blood pressure and how they feel. And we basically titrate the medication to a point where they're feeling comfortable enough. And typically when somebody gets a ketamine infusion, we don't want there to be any sort of extraneous factors that can deter them from just concentrating on the experience, because we don't want them to focus or rather not focus on their source of chronic pain. It's really a state in which one needs to accept the chronic pain that they're in. You need to focus on it and not deter yourself in that state. So we like to keep them in a dark room. We like to give headphones. We like
Really?
to
Okay.
Yeah, absolutely.
Okay.
Employ calming music.
This
we
is
want
an
them to be
experience
focused.
then. Yeah.
It's an absolute experience and really how it should be. Sometimes we will pre-medicate with a certain medication called midazolam, which is a benzodiazepine. It's obviously medication administered by typically anesthesiologists before surgery to help them calm the nerves a little bit. But the way I think about it is, we get the patient a little tipsy. You give them a little cocktail, help them calm down and relax.
Drink before, yeah.
A little drink before the storm.
Before the party, yeah.
Helps them calm down and it helps them not escape the experience. So when we give the ketamine, sometimes if we're not giving a pre-medication like that, I'm sure people have heard of what a K-hole, for example. Like, what is a K-hole? A K-hole is where a patient gets a higher dose of ketamine that's unanticipated, and they get stuck in almost like a locked-in state where they get tunnel vision and they can't escape this dissociation. So their heart rate goes up, their blood pressure goes up, and it's just a perpetual state of anxiety, which you can mitigate with the medication that I talked about, that midazolam, aka Versed.
Okay.
Yeah.
Okay. So yeah, you mentioned something that I think is very important, and one reason why I had you on the show. Again, as I mentioned at the top of the hour, talk therapy, medications, very beneficial for a lot of people, but sometimes not the case. Okay. You mentioned TMS. There's also ECT, and now we have ketamine to add on top of that. These are all just tools in the toolbox. Okay.
Absolutely.
Do a lot of your patients also take medications and also engage in therapy as they're doing the ketamine treatments?
Yeah. If they have not engaged in with a mental health professional partner up, I usually will hold off on the treatment and have them at least get a consultation, try that modality, because again, really we try to reserve this for patients that are, depression kind of resistant to these other modalities. So it's always very important to partner with the mental health professional throughout the treatment. In my opinion, it's the best outcome. Very similar to, for example, if you get an epidural injection and you go to physical therapy, those two things work best together. So same with getting a ketamine infusion and going to a psychiatrist. So, those modalities together, outcome studies have shown that those two in combination have given the best and most sustained results, as opposed to just one treatment versus the other.
Right.
Yeah.
Yeah. I'm glad you mentioned OB-GYN, because I definitely looked at your profile. I know you did some work.
OB-GYN. Which profile did you look at? No.
You didn't. You weren't an OB-GYN, but you did some work with providing epidurals, correct?
Yes, I did. Yes,
okay.
I did. Yeah.
That's my vision of
an anesthesiologist. Yeah.
Yes, one of many, but yeah.
Yeah, that's a very dark past. I'd like to not bring that.
It's an intense unit, right?
It is
very
intense. I think the most intense part about it is working with the nurses in the obstetric unit, because they could be demanding it for him. And, sometimes you're like, why didn't you call me at 11:30 when you're having pizza? We got to wait till 3 No, I'm kidding. I love my nurses. But OB's a challenge of its own. There's a different patient population you got to work with. It's very different from chronic pain. So I'm happy I don't do obstetric epidurals anymore, even though I will get consulted.
Right.
When should I get my epidural? When do you think I should do it? And these are all usually my fiance's friends and all that stuff.
Got it. Yeah. So we just spoke about ketamine. Okay. That honestly falls into a realm that I'm a little bit more familiar with in terms of medications. It's more of it goes into your body and can affect the body systemically.
Mm-hmm.
You also provide another treatment called Stellate Ganglion Blockade.
That's right.
Okay. So that's a little bit more focused. I think you can put a diagram up and say exactly what you're going to do, how you're going to do it, when you're going to do it. Okay.
Yes.
So in terms of that procedure, could you describe that for the people that have no idea what the hell I just mentioned? What is the Stellate Ganglion Blockade? I'm glad you brought that up, because that has been gaining a lot of traction. I saw it on your Instagram. That's how I found you.
Well, as interesting as social media is, it's got its benefits. And I was never one to purport, using social media to garner followers or it's more of a spreading awareness. And as a matter, it is what it is. Now we live in a generation where people get their information from Twitter. Wake up and check the news on Twitter because you feel like it's unbiased. So I feel like these social media platforms are a good way to provide some level of medical content, even though everything I put is like, to be taken, from a medical perspective with a grain of salt, because it's not professional opinion. You got to get consulted and all those things. But it's a good place to start and raise awareness. And I'm happy you saw that. And I guess if one person sees it, it makes a big difference. But that being said, so from ketamine to Stella, right, to stellate ganglion blocks. So ketamine got FDA approval in 2020 to be used as an oral medication, which was a huge step in the propagation of ketamine to be used for treatment-resistant depression. Now, stellate ganglion blocks, which it's an injection. That's what a stellate ganglion block is. It's an injection in the neck around this area here on the right side. For those who are watching the video,
yeah, they may be able to see. The front of you, where your throat is, everybody. It's just where your throat is.
Basically, where your throat's at. Adam's apple-ish.
There you go. Yeah, exactly.
So it's an injection that takes place near the throat, and is an injection that contains a local anesthetic. Now, the type of local anesthetic can vary. It could be lidocaine, it could be ropivacaine, bupivacaine. These are different kinds of anesthetics that we use. And what the injection does is when it's administered in the right place in the neck, which is usually near the C6 transverse process, we have 7 cervical vertebrae. And if it's administered near the 6th cervical vertebrae in a certain area, that's where you have the preponderance or most of the tracts of the sympathetic plexus, the cervical sympathetic plexus.
It's a bundle of nerves.
It's a bundle of nerves. Okay. There are different kinds of nerves that control the autonomic responses. Now, the cervical sympathetic plexus at your C6, again, where you inject with the stellate ganglion block, it's called a stellate ganglion block because it's the stellate plexus, okay? And it's a stellate ganglia, so it's a stellate ganglion block. So the purpose of injecting that is to anesthetize those nerves. Now, classically, we've done this injection to treat symptoms of CRPS, okay? It's complex regional pain syndrome. Just follow me here. Complex regional pain syndrome is a very distinct syndrome that's basically diagnosed by excluding other things. It's a very vicious pain cycle that happens by just any sort of noxious or painful traumatic experience. You can sprain an ankle and develop complex regional pain syndrome in the foot.
Okay.
You can sprain a wrist, and it usually happens in women, typically in younger women. And it's a pretty bad state of stiffness and chronic pain, reduced mobility. And one of the go-to gold standard treatments / diagnostic injections are this sympathetic ganglion injection, the SGB, the stellate ganglion block. For example, if somebody sprains their arm and they develop this complex regional pain syndrome, early diagnosis is important, because if you do that injection in the neck, what it does is it basically treats the symptoms of the pain. And sometimes a series of 5 or 6 of these injections can actually eradicate the pain significantly, which is like a blessing, because really that's the only treatment, that and ketamine. And so, as you can already tell, because I brought up ketamine, you're thinking, oh, the stellate ganglion block, maybe it functions like ketamine. Well, it actually does. So the way it works is if you do inject it in the right place and you anesthetize or you block that sympathetic plexus, what you get is a dilation of the vessels next to the nerves. Now, when you get a dilation or an expansion of the vessels, what shortly follows? An increase in blood flow. Mm-hmm. And with blood flow comes oxygen, come nutrients, and comes a washout, basically, of any of the compounds that could be sitting around or causing this pain state in the hand. So with the injection, you're going to notice a dramatic increase in the temperature of the hand, by at least 3 to 5 degrees. So the left hand will be normal. The right hand will be hot if you inject it on the right side of the neck. Now, because you get that dilation of vessels, guess what? You also get a dilation of the blood vessels going up towards your head. Now, with every treatment, we found that there's beneficiary secondary gains. And one of the secondary gains with stellate ganglion blocks is actually an increase in blood flow to the brain. Now, which part of the brain would be responsible for these emotions and fight or flight response and chronic pain and anxiety? The limbic system.
Yeah. Amazing, right? How that keeps, it's a theme in psychiatry and neurology.
Keeps coming around. So it increases blood flow to the limbic system.
Okay.
It increases blood flow to the hypothalamus. It increases blood flow to the amygdala. And by increasing blood flow, you're almost rebooting, the system. You're promoting blood flow, oxygen, nutrients to that part of the brain that's responsible for these symptoms. At the same time, a secondary action of the stellate ganglion block is reducing those circulating levels of adrenaline and noradrenaline. The drugs in our body that are responsible for the fight or flight. The heightened levels of adrenaline, noradrenaline, like we just talked about, are responsible for PTSD, anxiety, depression. Patients with depression have high levels of these. So with the stellate ganglion block, you are dramatically shutting off that in our body. So you're rebooting that system responsible for the anxiety and depression.
Getting twofold benefit from stellate ganglion block?
That's right. Basically, there's mechanism of action. So there's a mechanism whereby you increase the blood flow to that part of the brain, the hippocampus and rather the hypothalamus and the amygdala and the limbic cortex. That's responsible for all these emotions. And you're also dramatically reducing the levels of your norepinephrine and epinephrine, aka adrenaline, noradrenaline, or the fight or flight response. That's responsible for these heightened levels of anxiety, depression, PTSD, and chronic pain.
Okay. How long does the procedure last?
So procedures can last anywhere between, the effects of the procedure rather, last between 3 to 6 months. Sometimes can last shorter than that. Sometimes can last longer than that. Now, the procedure itself might take 15 minutes.
Really?
Yeah, it could be done under a local anesthetic. It could be done under a little bit of sedation through the IV. And I'd say 50% are just content with getting a little bit of topical anesthetic, numbing up the skin. It's done with ultrasound. And classically, it used to be done with X-ray. As we all know, X-rays show bones. They don't show any of the soft tissue. So back in the day, there were a little higher level of complication because you might inject in an artery or a nerve or a vein and not know on X-ray. But with ultrasound, which is what I use, there are significantly less complications. I want to knock on wood right now, but I have yet to see any complications.
I have no wood in this studio, so
need some wood.
Sorry.
So with ultrasound, you can see the soft tissues, you can see the nerves, the vessels, the veins, and you can actually deposit the medication in a much not only safer way but effective way. You can actually see the medication go around that sympathetic plexus, resulting in better outcomes and resulting in less complications. So some of the classical complications are bleeding, infection, and nerve injury, but these are essentially mitigated by using ultrasound technology. And so, like I said, it's about 15 minutes long. Most, half of the patients get it with just under local anesthetic, and it's done with ultrasound, and the outcomes could last for 3 to 6 months.
And in terms of response, so these are treatment resistant. Like patients don't come to you if they're moderate or mild depression. They come to you because it might be severe and it hasn't responded to medications.
Correct.
What sort of responses do you get? And we can also do that with, I think you might have mentioned that with ketamine, but if you didn't, what sort of responses do you get with these patients?
So
with these treatments?
I mean, this is probably my favorite question of the day because look, it's my favorite procedure that I do, and I do a bunch of different things. I do nerve blocks. I do nerve stimulator implants, which are like pacemaker implants for the extremities and the spine for chronic pain, epidurals, ablations for nerves, etc. But this is my favorite injection just because of how significant it is and how much it impacts the human being. And I see outcomes on a first-person basis. So I've had patients from all walks of life. I've had young adults who are 16 or 17 who come with parental consent. I've had older people in their 60s suffering from treatment-resistant depression. But a majority of the people I see are in my same age range. They're high-functioning individuals with good jobs who live in my neighborhood and my community down the street. And I see these people come in and they got a huge smile on their face and they're all so grateful and they're all so happy to be there. But what I don't know, which is, kind of under the skin, is how much they've been suffering from just chronic pain in their mind and anxiety and depression. And they can't sleep and they get palpitations and they wake up at night thinking about the problem and it progresses throughout the day and they try to close their eyes and it just keeps ruminating in their mind. And the most common thing that I hear after the injection is an immediate sense of calm, where those thoughts aren't ruminating in their mind. The second most common thing that I hear is that all of a sudden, and I've seen this a countless number of times, can't explain it, but they tell me that their fear just went from here and got pushed back to here, the back of the brain. And I've seen them make this gesture so many times, and I always try to think about it to see what do they mean by it. They manually show me that their anxiety and fear gets pushed back from here to the back of the mind. It's so interesting because I've seen it so many times, and
I've heard that with medications quite a bit. It's I think what they're describing to you is the fact that it's always on their mind. It's sort of like when you're driving down the road, you're just thinking about the drive. You're not really worried about all the other cars around you.
Interesting.
It's kind of like that.
Okay.
If you're just constantly thinking about something, but now you're aware of it, but you're not. It's not at the forefront of your thought anymore.
Okay.
I think that's what they're describing.
Well, that's interesting. So you hear that from medications as well.
Yeah. People, and even with something like schizophrenia, patients don't stop hearing voices. They can hear them. They're just quiet.
I see.
For a lot of people that are pretty severe schizophrenia, if the medications are working optimally, you don't go from like voices on a 10 out of 10 scale. They go from like a 2 out of 10.
Okay.
So now they can focus more on what they're doing. The voices are still there. When they get really anxious, they hear voices, right? Same thing with anxiety. Like they still worry about what other people are saying about them and things like that, but it's just not something that prevents them from moving forward with life.
Okay. So it's almost like it's more difficult to trigger that event, and it's kind of subdued in the back of the mind at that point.
Yeah.
Okay.
That's my interpretation of, because when I hear it with medications, of course, that's kind of what that sounds like to me.
Okay.
Yeah.
Well, I guess, that makes sense.
Everybody has anxiety. Everybody has.
Yeah.
Every time I do an episode, I have a little bit of anxiety about what I'm doing, but it doesn't stop me from engaging with you. You know what I mean?
Right.
I think about the cameras and everything, but I'm still locked in with you here.
Yeah.
That's just what people want. They're not going to be completely numbed out.
Right.
They still want to be present. That's kind of my interpretation of.
Well, I think that makes a lot of sense. It's like with any sort of even physiologic pain, everybody's got some element of pain. It's just a matter of if you're able to kind of calm and subdue it.
Exactly.
Versus it kind of falling out of alignment and it just turning into a chronic perpetual state.
Yeah.
And mental health is the more I see these mental health patients, is the more I realize how similar it is to just any other physical ailment. And it's sad that we don't have as many tools for mental health as we do for physical ailments, but I think we're getting there. And maybe it's just because I've been involved in the last few years, but I personally think in the last 15 years, we've made huge, tremendous strides, especially with the FDA approval of ketamine. And now with, more treatments and more outcome studies involving things like psilocybin and microdosing, and now they're holding legitimate medical research and outcomes showing these beneficial properties of these medications. So it's very interesting where we're headed. Sorry to veer off topic.
You're okay. Psilocybin, ayahuasca, ketamine, SSRIs, SNRIs. I don't give a damn what you do as long as it's safe.
Right.
It's all the same to me. Because the way I think about meds, and even with ketamine, you mentioned the NMDA receptor. The medications that you put in your body are not creating an NMD receptor. It's there. We're trying to just hijacking the system.
Yeah.
That's the way I think of it. So if you do that with ayahuasca, you do that with ketamine, fine with me. Just do it safely.
Right.
That's my whole thing. Same thing with cannabis. There's a safe way to do it. There's a not safe way to do it. If it's beneficial for you, great.
Right.
That's why you're here, because we're learning about all the different things you got cooking. So,
and you're right about that. We all of us have these like endogenous endorphins that are inherent to our bodies, and sometimes these things get out of alignment, and medication assistant at that point becomes critical to helping these endogenous endorphins kind of subdue themselves and go back into alignment, like any other pain process. But to your question, the most common outcome that I see after the stellate ganglion injection is, first and foremost, they feel a sense of calm, and they definitely verbalize it. The second thing was the anxiety and all those emotions getting pushed to the back of the brain. And almost an anecdotal story I want to tell you is a younger patient. And she came in with her mother, and she just was not making eye contact. And it was very hard to evaluate the patient. And I had gotten an email from the team asking if it was okay to do this injection for the patient. And in full disclosure, I work with a company. I'm one of the only treating physicians in Southern California for the Stellate Ganglion block, and the name of the company is Stellate Center. And Stellate Center is run by one of their leaders, Dr. Lipoff, Dr. Eugene Lipoff, who's also double boarded in anesthesiology and interventional pain management training and practicing out of Chicago. I trained with Dr. Lipoff. I had the luxury of doing that, and sort of took me under his wing and showed me the beneficial outcomes of stellate ganglion injections during my training. So I was exposed to it quite some time ago, probably back in around 2015 or 16.
Okay.
Got in contact with me while I was in California and was wondering, hey, we've got 20 million untreated patients in California. We need somebody to help.
20 million.
20 million. Yeah.
Okay.
And I, of course, was not hesitant to reach out to him and say I'd be more than happy to help. And so I've been gladly able to help treat our, patients suffering from these conditions through the help of Dr. Lipoff. But nevertheless, back to the story of that young girl. So they sent me an email asking if it's okay to treat somebody under the age of 18 because I don't traditionally do it. And we got parental consent. She came with her mother, and I felt so bad for her because she had tried everything, TMS and therapy, medications, ketamine. She'd gone through the gambit of everything. And so to my mind, I felt like she met the criteria and would be a good candidate for the SGB, or the stellate ganglion block, also known as a God shot, by the way, on Reddit, which I just recently learned about.
A God shot.
God shot.
Okay.
It's a pretty cool nickname.
Yeah, I think so too.
So I didn't want to exclude her from the therapy because she just, been through a lot. And when I saw her, she wasn't making eye contact. She actually had headphones on, big headphones like the ones I got on right now. And, I talked to her mom. I kind of gave her the lowdown on what the injection is, what to expect and all that. Took the patient in the room with her mom into the operating room because she had so much anxiety. Right. Gave her medication. She went to sleep, did the injection. I didn't see her after that for quite some time. 6 months later, I come walking in the preoperative area, ready to take a patient back for a stellate ganglion injection. And, I kind of do a double take. I go back and I see there's a woman sitting next to the bed, and it was that woman's mom. And I looked at the girl, and she had her headphones off, and she was smiling, and she was making eye contact. And I looked at the mom and said, is this the same girl, or does she have a sister or something? And she goes, no, this is her now. Like, look at how much her life has changed from where she was at to where she's at now. And at that moment, I realized, I was like, this thing works.
Yeah.
And it was from that point on where I started telling my friends about it, that, what, if you've got mental health issues, first and foremost, see somebody. Second of all, understand that there's different tools that we can use nowadays that are safe and effective. And so, just an anecdotal story there, but I've seen people from all walks of life, all professions. I've seen famous businessmen to famous tattoo artists to you name it, people traveling from San Francisco, from Houston, from the Midwest. And it's interesting to see all these people from different walks of life suffering from the same thing. And so far, I think about an 82% success rate.
82%.
Yeah.
82%.
Yep.
No, that experience that you had, it's fantastic. There's not much like it.
Yeah. And that's why I like doing, that's clearly why it's my favorite procedure to do is, good luck getting that kind of outcome with an epidural injection.
Well, I don't know about that. In the moment.
In the moment for an obstetric patient.
They're very thankful for you giving them that epidural.
Sorry, maybe a bad example.
Okay. Well, you just spoke about something that's very positive. What is the most challenging part? Like I mentioned, your patient population, my patient population. The only, I can't think of too many patient populations that don't have aspects of it that are very challenging. Because some patients are harder to help than others. Sure. For a variety of reasons. What's the most challenging part about your profession, your job?
So with pain management, there come a lot of hurdles. Of course, they're extremely grateful. I love my patients. I couldn't wish for a more rewarding job.
All right, everyone, we're going to take a short break. When Dr. H and I return for part 2, we will be discussing the most challenging aspects of being a pain specialist and also the current status of the opioid epidemic in the United States. Stay tuned. We'll be back soon.